Hello, good morning all. My name is Dr. Yang. Today's topic will be occlusion, and this is a very basic topic in orthodontics, and it's a simple one. I hope you will enjoy this lecture. This is the learning outcomes. By the end of the lecture, you should know how to define occlusion, myocclusion, and concepts of normal occlusion. You also need to know how to classify the different types of myocclusion, its advantages and disadvantages. You must also know how to outline the type of cups, and you should know how to list down the Andrew-Six keys for normal occlusion. So, what is the meaning of occlusion? So, based on Dolan Medical Dictionary, occlusion is the relationship of the maxillary and mandibular teeth when they are in functional contact during activity of the mandible. Occlusion is vital for all branches of dentistry, and the purpose of this lecture is to present orthodontically oriented concept of occlusion. So why we call this orthodontically oriented concept? Why not dentistry oriented concept or others? This is because in some books they define occlusion based on the branch of dentistry. So later when you have some more further reading, you will see there is some difference between orthodontically oriented concept and prosthodontically oriented concept. So in this lecture, we will only focus on orthodontically oriented concept of occlusion. Okay, another meaning of occlusion by Edward Engel is occlusion is the normal relation of the occlusal inclined planes of the teeth when the jaw are closed. These are the terminologies used in occlusion. First, ideal occlusion. What is ideal occlusion? Ideal occlusion is the concept of ideal or optimal occlusion refers both to an aesthetic and physiological ideal. It includes functional harmony, stability of masticatory system, and neuromuscular harmony. Secondly is the physiology occlusion. This occlusion shows no sign of occlusion-related pathosis, such as traumatic occlusion or crossbite. It may not be an ideal occlusion, but there will be no other pathological manifestation in the surrounding tissue, such as ulcer or gingival recession. Next one is balance occlusion. This is an occlusion in which balance and equal contacts are maintained throughout the entire arch during all excursion of the mandible, meaning that both upper and lower teeth will maintain a good contact when the mandible is moved laterally or anterior posteriorly. That is what we call balance occlusion. The fourth one is a functional occlusion. It is defined as an arrangement of teeth which will provide the highest efficiency during all the excursive movement of the mandible which are necessary during function. The key word for this definition is the highest efficiency. And then the next one is a therapeutic occlusion. It is a treated occlusion employed to counteract structural interrelationship related to traumatic occlusion. Okay, now we can see that the first photo shows there is a crowding on the upper and lower arch. When we put on the braces and then we may do some extraction, the teeth are all aligned. This is what we call therapeutic occlusion, the teeth that have been treated by braces. Traumatic occlusion and trauma from occlusion more or less carries the same meaning. Traumatic occlusion is an occlusion judged to be causative factors in the formation of traumatic lesion of disturbance in the orofacial complex, whereas trauma from occlusion is defined as periodontal tissue injury caused by occlusal force through abnormal occlusal contacts. Sorry for the spelling mistake. It should be periodontal tissue injury. So in both photos, it shows that due to traumatic occlusion, the tissue injury is a gingival recession of the lower teeth. The next one is type of cups. There is two type of cups. First one is the supporting cups, and then the second one is the non-supporting cups. What is supporting cups? is the facial cups of mandibular and palatal cups of the maxillary posterior teeth are called centric holding cups or supporting cups. Another name for it is stem cups. They occluded with the central fossae and marginal ridge of opposing teeth. The area of contact of the supporting cups with the opposing teeth in maximal closure should be well established and stable. The next one is non-supporting cups. What is non-supporting cups? It is the maxillary buccal and mandibular lingual cups are called non-supporting cups. They contact and guide the mandible during lateral excursion and shear foot during mastication. Hence, they are also called as shearing and guiding cups. So, in order to memorize what is the non-supporting cups, you have an acronym called BULL, which is buccal of upper and lingual of lower. So it's very simple, right? There are three types of imaginary occlusal curve, which is curve or Spee, which is also known as anteroposterior curve, curve of Wilson, which also known as mesiolateral curve, and curve of Monsoon. Curve of Monsoon is the combination of both curve of Spee and curve of Wilson. Now we will look into details what is curve of Spee. Curve of Spee was discovered by Mr. von Spee. This anteroposterior curve or curve of Spee was defined as the anatomical curve established by the occlusal alignment of the teeth as projected onto the median plate, beginning with the cusp tip of the mandibular canine and following the buccal cusp tip of the premolar and molar teeth, continuing through the anterior border of the mandibular ramus and ending at the anterior aspect of the mandibular condyle. So you can see all this explanation in one red line on the picture of the skull. A flat to slightly concave curve or Spee bears the proper occlusal surface for optimal occlusion. The next one is curve of Wilson. It is a mesiolateral curve that contacts the buccal and lingual cusp teeth of the mandibular posterior teeth. It helps in two ways. Firstly, the teeth are aligned parallel to direction of medial pterygoid for optimal resistance to masticatory force. Secondly, the elevated buccal cups prevent food from going past the occlusal table. The third type of curve is curve of Monsoon. It is obtained by extension of the curve of Spee and curve of Wilson to all cusps and incisor edge. It forms a sphere of a 4-inch radius. Mandibular arch adopted itself to a curved segment of a sphere. So, based on the photo, we can see that there is a imaginary line that connects the cups so that it will form the curves, and also the 4-inch radius that's explained better about the curve of Monsoon. Now is the classification of occlusion. So occlusion can be classified into centric or eccentric, functional and non-functional, lateral or protrusive, canine guidance or group function. I will be explained one by one in the next slide. Firstly, the centric relation. What is centric relation? Is the maxillomandibular relationship in which the condyles articulate with the thinnest avascular portion of their respective teeth with the complex in the anterior superior position against the shape of the articular eminence. This is something very anatomical, and you need to know clearly where is the position of the anatomical part. Centric relation is a bone to bone relation. That's why it's really anatomy related. It is a muscle determined position and it is not influenced by teeth and occlusion. whereas centric occlusion is tooth-to-tooth relation and it is a tooth-determined position. Centric occlusion is that position of the mandibular condyle when the teeth are in maximum intercuspation. So the keyword is the maximum intercuspation. Centric occlusion is also called intercuspal position or convenient occlusion. Centric relation and centric occlusion should coincide in order to have perfect harmony between the teeth, the TMJ, and the neuromuscular system. Some studies have shown that majority of the population have a maximum intercuspation 1 to 2 mm forward of centric. So the occlusion is related to the position of the condyle. Centric contacts are areas of the teeth that contacts the opposing teeth. There are three types of centric contacts, which is the posterior, anterior, and poded. Posterior centric contacts consist of the facial range of contacts and the lingual range of contacts of the posterior teeth. The facial range of posterior centric contacts involve the mandibular facial cusp teeth contacting the central fossae and mesial marginal ridge of the opposing maxillary teeth. Lingual range of posterior centric contacts involve the maxillary lingual cusp teeth contacting the central fossae and distal marginal ridge of opposing mandibular teeth. Anterior centric contacts involving only the anterior teeth. Anterior teeth have only one range of centric contacts and are in line with the facial range of posterior centric contacts. The poded centric contacts. It is the centric contacts that often occurs on inclines of posterior teeth. The inclines or slope of the guiding cusp from the guiding cusp tips toward the center of the tooth. These contacts that occur on inclines are called poded centric contacts. If the contact occurs on two inclines, the contact is termed as bipoded contact. On three incline is termed tripoded contacts. On fourth incline is termed quadrupoded contact. Now we will look at eccentric occlusion. Any occlusion relation other than centric occlusion is called eccentric occlusion. Eccentric contacts refers to contacts of the teeth that occur during movement of the mandible. Eccentric occlusion can be divided into two types, which is one functional occlusion and then second one is non-functional occlusion. Functional occlusion, also called working side occlusion, refers to tooth contact that occur in the segment of the arch toward which the mandible moves. So when the mandible moves to the right side is called functional occlusion. So when the mandible moves to the left side and then the left side is called functional occlusion. Functional occlusion can be two types. The first one is lateral functional occlusion, which is from side to sides. And then the second one is protrusive functional occlusion, is when the mandible moves forward. For the lateral functional occlusion, it includes tooth contact that occur on canines and posterior teeth on the side to which the mandible moves. It can be divided into two. The first one is the canine guided occlusion. During lateral mandibular movement, the opposing upper and lower canine on the working side contact, thereby causing disocclusion of all posterior teeth on the working and balancing side. Canine guidance occlusion is usually seen in a young individual with unworn dentition. Secondly is the group function occlusion. In addition to canine guidance, certain other posterior teeth on the working side also contact during lateral movement of the mandible. In a periodontically weakened dentition, sometimes the posterior teeth, usually premolars, also come into contact during lateral movement of the mandible. For the group function occlusion, usually it happens in an older person because the canine is already worn, so that's why there is a contact on other posterior teeth, for example in canine, premolar, and sometimes in molars. For the protrusive functional occlusion, it includes eccentric contacts that occur when the mandible moves forward. Ideally, the six mandibular anterior teeth contact along the lingual incline of the maxillary anterior teeth, while the posteriors disocclude. For the non-functional occlusion, there are tooth contact that occurs in the segment away from which the mandible moves. For example, if the mandible is moved to the left side, contact occurs on the right side of the arch. Now we move to Andrew Seed's case of optimal occlusion. This Andrew Seed's case of optimal occlusion is invented by Dr. Lawrence Andrew. He collected 120 non-orthodontic models from 1960 to 1964, and from this model, he selected the study model who had never done any orthodontic treatment, and the teeth were straight and pleasing in appearance. And the study model also has a bite which looked generally correct and will not benefit from orthodontic treatment. He then compared those 120 non-orthodontic models into 1,150 treated models. He studied the difference between best in treatment result versus best in nature, which gave birth to the Seed's key of optimal occlusion. So now we will look one by one into Seed's keys to optimal occlusion. Key number 1 is inter-arch relationship. This key consists of 7 points. The first one, the mesobuccal cups of permanent maxillary first molar occludes in the groove between the mesial and middle buccal cups of the permanent mandibular first molar as explained by angle. Second, the distal marginal ridge of the maxillary first molar occludes with the mesial marginal ridge of the mandibular second molar. Third, the mesiolingual cups of the maxillary first molar occludes in the central fossa of the mandibular first molar. Number 4, the buccal cups of the maxillary premolars have a cups embrasure relationship with the mandibular premolar. Number 5, the lingual cups of the maxillary premolars have a cups fossa relationship with the mandibular premolars. 6. The maxillary canine has a cups embrasure relationship with the mandibular canine and first premolar. The tip of its cups is slightly mesial to the embrasure. Finally, number 7, the maxillary incisors overlap the mandibular incisors and the midline of the arch match. Key number 2, mesiodistal crown angulation. The degree of crown tip is the angle between the long axis of the crown and a line drawn 90 degrees from occlusal plane. For the occlusion to be considered normal, the gingival part of the long axis of the crown must be distal to the occlusal part of the line. You can have a look on the picture at the side. It is called positive when the gingival portion is distal to the incisor portion, and it is called negative when gingival portion is mesial to the incisor portion. Key number 3, labiolingual crown inclination. The crown inclination is determined from a mesial or distal view formed by a line 90 degree to occlusal plane and a line tangent to bracket side. If the gingival area of the crown is more lingually placed than the occlusal area, it is referred to as positive crown inclination. In case the gingival area of the crown is more labially or buccally placed than the occlusal area, it is referred to as negative crown inclination. For the anterior crown inclination, the maxillary incisor and mandibular incisor shows a different inclination. For the maxillary incisor teeth, it shows a positive crown inclination, whereas for the mandibular incisor, it shows a very mild negative crown inclination. For the posterior crown inclination, the maxillary and mandibular posterior have a negative crown inclination. Key number 4, absence of rotation. The fourth key to normal occlusion is that the teeth should be free of rotation. If molars rotated, it will occupy more space than normal. Rotated incisor occupy less space in the arch, so it will create a situation unreceptive to normal occlusion. Key number 5, tight contact. To consider a occlusion as normal, there should be tight contact between adjacent teeth. So the teeth should be well aligned, and it should be no spaces between the teeth. So we can see the first photo is an ideal photo of occlusion, and the second photo is not ideal because there is spaces between the teeth. Key number 6, curve or spee. The plane of occlusion found in the non-orthodontic models range from flat to slight curve or spee. A flat plane should be treatment goal as there is natural tendency for the curve or spee to deepen within time. So how do you know that the cases have a deep curve or spee? So when we see the photo, the either one patient have a flat curve or spee, and then patient will have average overbite. And the second one, the curve or spee is not ideal, meaning that there is a deepening of the curve or spee. In this case, when the teeth are in occlusion, that patient will have deep bite. So curve or spee and deep bite and overbite, both are linked to each other. The last key is key number 7, correct tooth size. Bolton tooth size ratio is considered as 7 keys of occlusion, so that the tooth size of the maxillary and mandibular arch should match for the proper overjet and molar relation without any spacing or crowding. Bolton analysis is an analysis that the orthodontist will do prior to treatment to analyze tooth size discrepancy. The potential need for interproximal reduction to decrease tooth size in one arch or restorative procedure to increase tooth size in opposite arch should be considered with patient or parents before treatment. Do you realize that this is an additional key because the Andrew should only have 6 key to normal occlusion. So key number 7 is additional because it's also will help in getting a normal or good occlusion. Okay, this is some textbooks that I can suggest you for further reading. So basically, I think for me personally, I like to read Introduction to Orthodontics by Laura Mitchell. I think it's suitable for you for BDS level. And then if you want to have more knowledge in orthodontics, you can read Handbook of Orthodontics and Contemporary Orthodontics by William Profit. Actually, is a master level. And then Orthodontic at a glance is, I think, is better for final revision when you already know all the basic things. So for me, I recommend you Introduction to Orthodontics by Laura Mitchell. Okay, for now, there is the end of my lecture. If you have any question, you can email me at my email, rafida@pidc.edu.my. So for this, thank you for your attention and have a nice day. Bye.